Good afternoon, everyone. Good afternoon. Welcome, Rotarians and guests. We're delighted to have everyone here with us today. We're the Rotary Club of Gainesville. Today is Tuesday, April 19th. At this time, guests and visiting Rotarians, if you're joining us on Zoom, we please ask that you identify yourself in the chat. And if you're watching on YouTube, please register your participation by sending an email to info@rotarygainesville.org. Pete Inwall.
Hey, all right, go Gators. Yes. Okay. Today's joke comes courtesy of Tom Collette. Thank you, Tom. A young man turned 17 and got his driver's license without restriction. And he went to his dad and said, "Dad, when can I expect to get a car?" And the dad said, "Well," he said, "son, if you bring your grades up, and I want you to read the Bible every day for a month, and I want you to cut your hair. You do all those things, then we'll talk about a car." Well, the son came back to him a month later and said, "Okay, Dad, I'm ready. And I brought my grades up. I've read my Bible every day." And the dad said, "Well, yeah, but you hadn't cut your hair." And the son said, "What's just hair?" I said, "I read the Bible, and I read about Moses, and I read about Samson, and I read about Jesus, and they all had long hair. So what do you think?" And the dad said, "Well, you'll notice that they all walked too." We're going to sing "God Bless America." God bless America, land that I love. Stand beside her and guide her through the night with the light from above. From the mountains to the prairies, to the oceans white with foam. God bless America, my home, sweet home. God bless America, my home, sweet home. Join me in pledging allegiance to our flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Pete. At this time, Laurie Vidal will share our invocation with us.
In light of our program today, which I'm looking forward to, I thought a prayer that I found online might be very appropriate as we think through the whole issue of something that's happened in many of our lives or in our friends' lives. So let us pray together. Dear Lord, you are, without question, the great physician. And we turn to you in our sickness, asking for help. We put ourselves under your loving care, praying that we may know your healing grace and wholeness. So many of us have experienced, friends or loved ones, or even personally, the struggle with cancer. Help us to find love in this strange world. Help to feel your presence by our bed, both day and night. And give our doctors and nurses wisdom that they may understand our illnesses. Steady and guide them with your strong hand. Reach out your hand to us and touch our lives with your peace, we pray. Amen.
Thank you so much. You may be seated unless you are a guest, and we'll have visitors and Rotarians introduce our guests. And I'm going to go ahead and go first because I actually have a guest with me today. So my guest today is Jen McConnell, a nurse practitioner with Celebrate Primary Care. Welcome, Jen.
Good afternoon, Greg Young. My guest today is Sarah Conkler. Some of you may recall she was with the Wyndham staff, and now she's moved into a new position as operations managers for Swamp Fitness here in Gainesville, a personal training in-home fitness company.
Okay, does that take care of all our visitors? Okay, great. We are going to go into announcements. TJ, I believe you have a fun and fellowship announcement for us.
Howdy, everybody. On Thursday, April 28th, we're going to be doing a tour of Reed Hayes's facility over at UF Innovate. He's the person who does risk management type stuff for retailers. So we're going to be doing that April 28th at 6 p.m. Right off of 2nd Avenue. You will get an email for sign up. So I hope to see you there. Thank you.
All right. Thank you, TJ. Ed Ellett, you want to come tell us about another fellowship opportunity? A delicious one, right?
I have a bit of an impromptu announcement after a call from President David and addressing a few things, concerns each of us had. But with Whirlwind Planning, we are going to have a Rotary Lobster Steak Fellowship again this year. And it's been 2 years since we last did it. It's going to be on May 1st, Sunday. On your tables or sign up list, be sure to pass it around so everybody can get on it. We're going to have to plan fairly quickly this go around. I've talked to the Hills folks. They have the available date. The chair and tables folks have an available date. So it was just like it was meant to be, even though it was short notice. The menu will be lobster or steak will be the main course. Home style green beans, garden salad, corn on the cob, garlic toast, key lime pie, sweet, unsweet tea, water, beer, and wine. How many here have been to a lobster feast before? Okay. And there are a number of people that have never heard of it before. You can see people you can check with and ask about. Cost this year is going to be $45 per person for a lobster, $35 per person for a steak. That's up probably about $10 for both of those from what it was in 2019, but it's still a palatable amount. We've got a modest club subsidy, very modest, but a subsidy, some group buying power, and there's no facility cost because it's at my wife and I's home. Advance payment is going to be required this year. Another compliment that we haven't had in the past is DAC-DB. And we can get out some notices and be sure that's taken care of to give our treasurer, Jeff Sims, a little relief. We also will need to pay the bill soon after the event. And then just a brief history, final thing. The first Lobster Fellowship was when Davis Rembert was president back in 1979 and 1980. And following that, Buddy Crevasse hosted a few at his home. There were one or two at the Girls Club. And Marcia and I picked up in 2004, and we had one a year event all the way through 2019, was called off in 2020 and 21. And after 19, we had between ourselves decided, well, I think we'll do it just one more time. And then the 20 and 21 came along. And so with this coming up, it's kind of a nice opportunity for us to do it one more time. This will be our last time we do it, and we hope all of y'all can come. So be sure and pass the sign up list around. Thank you very much. I'm available if you have questions afterwards.
Appreciate that. And Kirk Klein would like to talk with us briefly about junior achievement.
So really quick announcement. You might remember a month ago, Junior Achievement was programmed. Tonight at the Cade, sip and support from 5:30 to 7. First Magnitude Brewery will be there. Some wine. Feel free to come by anytime in between 5:30 and 7. And this is really the last week, and then the J Biztown will be taken down. So I don't know what that means for the club, if we can get back in there or not. But anyway, if you can come, we'd love to have you. Don't worry about RSVPing. Thank you.
That's terrific. Okay, well, at this time in the program, I'm going to turn our program over to our president, David Goday. Sorry, Eric, how did you like that? David Gracie, I stand corrected. Two great men, though, two great Rotarians.
I could think of worse guys to be confused with, for sure. Welcome. Good afternoon, everybody. Thank you all for being here today in person. And everyone that's attending virtually. I'm so glad each of you are here. A lot of you I communicate with throughout the week, and you remind me that we've still got a good contingency on Zoom, and I'm just so appreciative of that. And again, thankful for Joe Floyd, who with Wesley and Matthew's help makes all that happen. Yeah. So again, welcome. This is to our last meeting here at the Cade Garage Annex. That's what we call it, right, Amanda? Am I getting that? Yep. We're going to be going back across the street to the main museum, the Rotunda building. Right, Jenna? Yeah, we're excited about that. So we'll be back at our home base. But I'm glad we've been able to, excuse me, make do here. And there will be a group of us quickly breaking down the chairs and tables. We're going to be getting things out to Hatchet Creek, these items that belong back out there. And then a lot of this AV equipment will be going across the street. We've got several of us helping, but if you have time, we'd appreciate anyone's help if you got a few minutes to stick around. Melanie, thank you for that introduction. And I thank everyone for the important announcements that we had today, especially Ed Ellett's announcement. I know this is merely a fellowship event, but this goes back to my theory that these fellowship events are so important for our club and important for all the good that we do in the community, all the good that we do globally. And, it helps us do this, serve to change lives. We're helping to fund all the initiatives by just doing this stuff, having the continuity in our club. And so Ed's right. He kind of gave in pretty easily when I gave him a little arm twist on Saturday. And that was pursuant to several phone calls from many of you who conveyed your interest in having the Lobster Fellowship return. It's such a great event. We're out there at Ed's house, which is backs right up to Payne's Prairie, just a beautiful, I like to call it rugged beauty out there, right, Ed? And we're going to get this just under the wire before the mosquitoes get real bad. So really sign up. That's right. That's right. But please do sign up. I know TJ is going to be getting an email out so that you're able to sign up via DACDB. That's going to kind of help us, convey this along, and hopefully, we want to have a good showing out there. It's going to be a lot of fun. So I'll move on from that. And kind of talking about the lobster event reminded me of our dear fellow Rotarian, Dalton Birch, who I've talked to you guys about. And I'll tell you honestly, I haven't been back to see Dalton this week, but with the Lobster Fellowship planning, I'm saying this honest truth. It made me think of Dalton because I don't think he's missed one of those, Ed. He's a regular. He and Ann Gay just love that event. So anyway, I just want to let you know Dalton is doing a lot better. His daughter Megan told me that his oxygen levels are way up. He's still at the rehabilitation center there at Oak Hammock, but she tells me that he looks the best he has looked in years. So that's pretty awesome. So I'm glad to report that. Finally, this just came to me a few minutes ago. Our fellow Rotarian Kay Mitchell was involved with. I'll just tell you, it's communicating with the Matheson Museum and getting essentially a lot of the archives from the Rotary Club of Gainesville. These are things that go back to the founding of our club, which is, I asked Wes, I think it's 1919. Well, I know we've been around for 100 years. 1918. So it's been a long time. So this is cool. I mean, this is stuff like E.T. York's travels around the world as district governor and all the stuff he was involved with. A lot of old relics like old badges and a lot of documents. this is just really neat. And it's nice that the Matheson Museum will now be taking care of this. And Kay even mentioned that, we're going to have an exhibit set up at some point. And so that's really a neat thing. Thank you, Kay. So I am going to now ask Eric Godet to come up and introduce today's speaker.
Thank you, President David. Okay, so we are in for a treat. Today's speaker is Danielle Rogers. And with Danielle today, we have CJ Johnson, who's the VP of Oncology. And also we have Linda Turner, Director of Radiation Oncology. And so to tell you a little bit about Danielle, so I can get out of your way and you can enjoy this incredible presentation. Danielle is an advanced oncology nurse practitioner with over 21 years of oncology specific experience. She graduated with her Bachelor's of Science in Nursing from Georgia College and State University in Midgeville, Georgia in 2000. She later entered the Georgia College and State University graduate program and received her Master's of Science in Nursing as a family nurse practitioner in 2007. Danielle has worked in radiation oncology and medical oncology throughout her nursing career. Danielle is also a member of the Sigma Theta Tau Honor Nursing Society and is also board certified by the American Academy of Nurse Practitioners. She is also certified as an advanced oncology certified nurse practitioner through the Oncology Nurse Credentialing Center since 2016. Danielle completed her training in genetics through the City of Hope intensive course in genomic cancer risk assessment and continues as a member of the clinical cancer genomics community of practice through the City of Hope. She is on their high-risk work group committees. She is also certified as an advanced clinical genomic nurse, hereditary cancer syndromes. Her main area of focus is on those hereditary cancer syndromes, which continues to evolve in the exciting extensions of the oncology field. She enjoys educating the community and providers on prevention and risk-reducing strategies and helping collaborate in the care of high-risk patients and their family members. Please give a great Rotary welcome for Danielle Rogers.
Thank you, Eric. That was a beautiful introduction. I don't think I've ever been introduced like that. Thank you all for letting me come and speak with you today. Again, my name is Danielle Rogers, and I'm going to be focusing on the genetics of cancer. A lot of people will kind of talk dismissively about genetics. Like we talk about, oh, you've got good genetics, good genes. And there is a lot to genetics because genetics makes us who we are. And when we look at it from a clinical standpoint, there is a lot of clinical background in the diseases that we diagnose and treat. And the question is, are we going to be able to utilize genetics in the future to hopefully prevent, to guide us into personalized medicine, to determine appropriate treatment for patients? And of course, my favorite part is the prevention and making a difference in these families' lives. I always say, from a hereditary cancer standpoint, working in oncology, we always talk about survivors. From a hereditary cancer standpoint, when I can identify at-risk individuals and put into place options to help reduce risk or prevent cancer, then I make previvors. And that is what I would like to see more of in the specialty that I serve. I'm gonna let you click because I don't. Sorry. It's on, yeah. Well, that's okay. I'll keep talking. So I've made some slides. I do like to use pictures. I wasn't sure of my audience, how many people had a clinical background, who didn't. So I did try to keep it as simple and straightforward, but I do apologize if some of it seems very rudimentary. But genetics makes us who we are. It's about what's in our DNA, and our genetic blueprint is present in every cell in our body. So no matter what parents try to do to accuse their child being more like their mom or dad, we're 50-50. So you can't use that excuse anymore. Well, inside of our DNA resides our chromosomes, which makes up that genetic blueprint or our genome. And in there are genes. So when you look at the human genome, we have over between 21 to 25,000 different genes. Now, that is a lot of genes to focus on a lot of different potential issues. So I pretty much focus on a particular neighborhood. And this is where we can look at genes that we all carry. However, what we have found is that individuals can inherit changes on these genes that can put them at an increased risk for cancer. Do you want my thumb drive? So with genetic testing, how we determine who's appropriate for testing, obviously not everyone is going to carry a hereditary risk for cancer. What we know today is that only about 10% of cancers are related to hereditary changes. That means these are families that have inherited a genetic mutation in a gene that has put them at a higher risk for developing cancer. What a lot of people, may misconceive or not understand is that carrying a genetic mutation does not mean you're going to develop the disease. Thank you. So sporadic cancers are cancers that happen by chance because we're human, because we age, because we have environmental exposures, lifestyle factors. That accounts for the majority of cancers that we diagnose and treat. So oftentimes when I'm speaking to patients who are genetically normal, essentially, I have to remind them that surveillance and screening is still important because common things occur commonly and sporadic cancers are still the more commonly occurring situation. The next thing we look at is familial cancer. Familial cancer are these families where there's a significant family history, but yet their genetics is normal. So I always kind of look to it as the fact that there could be some genetic changes we don't know about. There could be shared environmental risks. And so probably about 35 to 40% of the patients that I see that are genetically normal on their genetic testing still qualify for enhanced screening. That means they may need to start screening younger. I mean, there are young women who are genetically negative that I may need to start mammograms at 30. There are young men who need to start prostate screening in their 30s. There are people that may need to start colon screening in their 20s, but yet their genetics is normal. So we still look at family history. And again, hereditary cancers are about 5 to 10% of these occurrences. So the question is what cancers can you see with these hereditary cancer syndromes? Well, if you all are familiar, there was a gene or two genes that we identified mutations in the early 90s called the BRCA. People like to call them the breast cancer genes. And again, this is a gene, both of these genes we all carry. These genes actually act as tumor suppressor genes, meaning they should help repair damaged DNA. Well, what we found is that mutations in these genes in the early 90s highly predisposed women's risk of developing very early onset breast cancer, as well as potentially ovarian cancer. As our research has evolved, we have discovered that this can also be associated with prostate cancer in men, male breast cancer, pancreatic cancer, and melanoma. With the evolution of genetics and improvement in technology, we have identified mutations in many different genes that reside in the same neighborhood as BRCA1 and 2. And we found that pretty much just about any cancer you can think of probably has a hereditary component. More recently, there has been a mutation that has been found with hereditary lung cancer, which we did not feel existed. There is also a whole nother realm of hereditary cancer genetics where we're looking at blood cancers. We did not think that leukemias or lymphomas or things like that could be hereditary, but we are now finding that they are. But some of the more common cancers, breast, prostate, colon, those are very common cancers. We probably have all known someone with these cancers. The other thing that we've identified is there can be certain features of cancers that can be commonly associated with hereditary cancer syndromes. So in that, we have developed guidelines that kind of lead us to determine who would be most appropriate for genetic testing. So there are certain patterns that we're looking at in family histories, or we're looking at how a person's disease manifested. So one of the things that a lot of people are surprised to know is that, any woman with ovarian cancer, we should test. That is the consensus in genetics, because what we have found through research is that 15 to 20% of women with ovarian cancer will harbor a genetic mutation that could be passed down to their daughters. It could be passed down to their son, who could then pass it to the granddaughters. It could be present in their sisters. The thing is a lot of people will say, well, I don't want to know. Why would I want to do testing? Why would I want to know that my risk for ovarian cancer is 63% when it's about less than 1% for everyone else? Well, the thing is we can make a difference. We can help prevent and identify these risks early enough. And there are even opportunity that if something is going to happen, we can find it at a very early stage. And even some of the most aggressive forms of cancer, if found early, have a better chance of survival. So the thing is how do you test for hereditary cancers? Well, it's through genetic testing. Usually when I say that, people kind of look at me puzzled, like, well, what does that involve? So I usually start by scaring them and saying, well, I'm going to have to clip half of your eyebrow and then take your thumbnail. I'm just kidding. I don't have to do that. It is literally as simple as a blood test or a saliva sample. There is the rare patient that I may have to do a skin biopsy on, but that is not the common scenario. Most of the time, it is as simple as drawing a blood or having someone spit, in a tube. So just so y'all know, I did get permission to put their pictures up here. I talked to them this morning. No, I'm just playing. So the thing is, can you make a difference? So many of you may recognize this picture. This is an actress, Angelina Jolie, who came out about 7 years ago and announced to the world, hey, I had both of my breasts removed. People could not believe it. They were like, why would you do that? Why would you have your breast surgically removed? Well, what she found out is her mother had died at 56 from ovarian cancer. So in one of her office visits, her doctor said, I think you should have genetic testing. So she did. And what she found from her genetic testing is that she had inherited a mutation in her BRCA1 gene from her mother that increased her risk of breast cancer as high as 87% compared to 10 to 12% the general population. She also had an increased risk for a second breast cancer. So even if she had one, she still could develop a second breast cancer. And then she also found that her risk for ovarian cancer was as high as 63%. So she was presented with options. They said, okay, so your risk is different. Mammogram alone is not going to be enough because you don't have the average risk of other women. So they presented her with options for enhanced screening, which means she'd have to have some form of imaging every 6 months, breast exams every 6 months, with the understanding that we may not prevent it, but we might find it early. Or she was offered the option of a preventative mastectomy, and that is the surgical removal of both of her breasts. So she elected to do that. That is felt to reduce her risk of breast cancer by greater than 90%. The thing about it is a lot of people will go, well, that's crazy. She's a superstar. She can afford it. Health insurance covers this preventative surgery in these at-risk women. It also covers their reconstructive options. So these women do not have to lose their breast and not be able to have a decent cosmetic outcome. So that is something we do because insurances have finally realized it's a lot cheaper to prevent cancers than to actually treat them. She went on 2 years later and decided to have both of her ovaries and fallopian tubes removed to try to reduce her risk of ovarian cancer, which did reduce it by greater than 96%. This is another actress, Christina Applegate. Many of you may remember her from Married with Children. She was diagnosed with a very early onset breast cancer in her 30s and underwent genetic testing, and she was found to carry mutation in BRCA2. She decided at the time of her breast cancer diagnosis to remove both of her breasts because, like I said, she's had this one breast cancer, but she knew she had an increased risk for a second breast cancer. And she also went on to have her ovaries and fallopian tubes removed. But something that she did is she realized a lot of these young women that were having testing that were being identified had a lot of socioeconomic issues. They either were uninsured, underinsured. And if many of you don't know, a lot of the surveillance and screening these women need are very expensive. Most of these women have to have a breast MRI every year. That can be upwards of thousands of dollars. That a lot of these young women, they may be single mothers, they may be in college, because again, we start these women in their 20s if we know early enough. So she kind of paired with a group called Right Action for Women to actually create a fund and a foundation to help pay for women who could not afford their screening. And I have utilized it many times for many of my patients. And it has made a difference between allowing them to have access to screening that may save their life. So that is something that she not only did for herself, but she also gave back. Many of you may recognize the woman on the right, Beyonce, but it's her father that I'm going to talk to you about. So this is something that is always surprising because people seem to assume this is a woman's issue, and it actually is not. These genetic mutations can be passed in a paternal as well as a maternal line. And the thing is men can inherit these mutations and they can have a risk for cancer. So Beyonce's father was diagnosed with male breast cancer. So following his diagnosis, because, whoa, you have breast cancer and you're a man, that's not common. We need to do genetic testing, only to realize that he did have a strong family history. And what's sad about it is if someone had just asked him that family history years before, he could have had genetic testing and probably would have been prepared for the potential of this risk, maybe even could have prevented this. So he was found to carry a mutation in the BRCA gene, but that is a thing that, we're trying to bring more awareness to, because not only was his risk for male breast cancer elevated, so is his risk for prostate cancer. And if y'all don't know, African-American men already have an elevated risk for prostate cancer. Throw a genetic mutation into it, then you're talking about, an even more of a risk. And what we have found through genetic research is the prostate cancer that's associated with BRCA2 mutations occur earlier in age. They're more aggressive. And some of these men do not survive if it's not found early enough. So this is very important to know. And we actually start these men screening in their 40s. I do have a story, particularly about a family where I saw a patient who was 79 with ovarian cancer, her first cancer ever. So she was referred to me for testing because, if you recall, I said we test every ovarian patient. Well, I get her in and her family history is horrendous. And she told me, she was like, I know, right? And I said, so nobody's ever had this conversation? She said, no. She said, I thought I had outlived my risk. And I said, no, fair enough. So we tested and she did have a mutation. And I also tested her tumor tissue. So it was in her tumor tissue and her blood. So we do know it had an attributable, association with her ovarian cancer. So then I get her children in and I test her 3 daughters and her son, and her 3 daughters were lucky enough to not inherit the mutation. So their risk was felt to be comparable to that of the general population. However, her son was positive. So I had this conversation with him, much like somebody would have had with Beyonce's father, about the male breast cancer risk, prostate cancer risk. And he's a busy mechanic. He didn't have time to go to the doctor, but I said, you need to go, you need to have prostate screening. Indicated that. He went to his family doctor, just like I told him to. And his family doctor said, you don't need to worry about that. That's a woman's problem, and sent him on his way. A year and a half later, I get a call from Emory. He has got metastatic prostate cancer, end stage, and they would like a copy of his genetic results. So again, I still want men to know this is extremely important for them, because it can impact them, but it can also impact the people that matter to them most, and that is their children and their siblings, and the same for women as well. Now, Beyonce and her sister tested and they were negative. So there's a success story. Dad did have them go and get testing. So how we change lives. One of the things we do is if we know someone has an elevated risk, we're going to modify their screening. Like I said, some of these women and men may need to start screening in their 20s, 30s. And the thing is they may have to have screening more often than the average person. There are hereditary colon syndromes where we start screening in between 20 and 25, and they have a colonoscopy every 1 to 2 years for the rest of their life. We even do this in colon cancer survivors who have a hereditary risk, because we know their risk of a second colon cancer is still there. Early detection, we all know, saves lives. I'm sure we've all seen it. That's why we drive that home about age-appropriate screening, getting screening for the hope that we find something early. Prevention is where we can utilize preventative surgeries. Risk reduction, there are things we can do to help reduce risk. So there are women I can give them estrogen blockers that can help reduce breast cancer. We can give aspirin, which helps reduce inflammatory polyps in some high-risk patients. So there are opportunity for us to do that as well. And again, creating previvors instead of survivors. And then two, the best thing we can do is help people understand their risk and giving them the choice on how they want to manage that risk. I don't ever want to take that choice away from a patient. It's one thing if you know you have a risk and you're like, I still don't care, I'm not going to do anything. That's okay. At least you know. But if no one's ever given you a chance to know, then how can you honestly say that you would have done something different? And then, of course, helping prevent disease in their family members. I always tell everyone, I may get referred a patient for testing, but when I find a mutation, I inherit a family, because then that's when everybody else that's close to them starts coming in for testing. And the thing is not only do I end up caring about them, but I do care about the people that matter to them, and that's their family. So just some of the stories, and I gave the story at the Board of Trustees, but it's one that just really hit with me. I had met with a girl whose sister had died at 33, 35 from breast cancer just 2 weeks prior to her office visit. So they had just buried her sister, and she died from metastatic breast cancer. Prior to her sister's death, the sister who had passed had undergone genetic testing only to find out that she had a mutation associated with her breast cancer. So the sister now that had not had breast cancer was coming in for genetic testing. So this is a very vulnerable situation, because I have to understand what is going through this family's mind. I've got this mother and this sister of this deceased person that's coming in for testing. So we go through the whole conversation about genetic testing, what it involves, what could happen if she comes back positive, what her options are. And so I look at her and I was like, okay, I said, let's say you're positive. What are you going to do? And she was like, that's a no-brainer. I'm like, okay. And she says, I'm going to do the bilateral mastectomy. And I said, okay. And she says, and then I'm going to have my ovaries removed. And if I could do it all at one time, that would be great. I said, well, we'll talk about that when we get there, if that's the case. And I said, what is your motivation? And she said, every woman on my dad's side, because this came from her father's side, not her mom's. Every woman on my dad's side of the family has either had cancer and died, or suffering with it now, or just waiting for it to happen. She says, I choose to not be a statistic. So she came back positive. She did have her mastectomy and ovaries removed all on the same day. I saw her a year later for follow-up, and it was like the weight of the world had been lifted off her shoulders. She was smiling. She felt free. She says, I have been living in fear that this was going to happen to me. And she said, and my sister, even though she lost her battle, gave me the gift of genetic testing so that I did not have to end up like she did. And that has never left me, ever, ever. I always remember that statement, because again, her sister gave her the choice. So again, people always want to know who should have genetic testing. Again, it all is based on patterns. What cancers are in your family? Are there multiple family members with related cancers? So 3 women with breast, 3 people with colon. Is it breast and ovarian? Are we seeing prostate, pancreatic, and breast in one family? So again, a lot of people don't know, and it can be overwhelming, because a lot of providers will go, gosh, I can't keep up with all the guidelines. I don't know what to handle. I oftentimes will tell them, if there are patients who are concerned about their family history, just send them to me, because I'll be able to break down that family history and determine who's appropriate. And the thing is if they're not, there's still about 35, 40% of them that are probably going to need some extra screening and kind of just additional care related to that. So I would rather educate patients and let them know. So I showed this, and when I did the talk at the Board of Trustees, I did not have this full PowerPoint. I had one slide and this was it. So I actually love it. So it has this sweet little man at the pearly gates, and he's got his cane and his briefcase, and he says, I'd have been here sooner if it hadn't been for early detection. So, but are there any questions? Yep. Go ahead. The woman in the back, I'm sorry.
This is really fascinating. And you mentioned that you can do the genetic testing.
Mhm.
And with all these like Ancestry, Me, and the programs that we can do, and they have an option for you to get a medical background screening. How do those tests compare to what you provide?
So thank you for asking that, because there is a lot of commercial to consumer testing available. And they're targeted more at Ancestry, but there are some medical things that they do. 23andMe claims to do the BRCA testing, but actually what they do is they assess for 3 founder mutations that are common in people of Ashkenazi Jewish ancestry. Just to put it into perspective, we've identified over 2,000 different mutations in BRCA1 and 2. So that means they're only looking for 3. So if they bring me a genetic test result from one of those consumer, commercial to consumer, I'm usually going to do more confirmatory testing through one of the laboratories that we use from a medical standpoint. But I will be honest, I do think we will get into an era where we are doing population-based testing. I think genetics is really the future of medicine as far as prevention. Thank you. Yes, sir.
Great program. I just had a question regarding both of my daughters are adopted.
Okay.
Is there any recommendation for if you have no history, no connection
So-
to?
Yeah, that
Parents?
comes up often. You know, a lot of times, you know, I'll ask because some, you know, adopted individuals do have some access to medical records from their biological parents. Some don't. In genetics, you know, a lot of times we don't just jump on board to test people without, you know, some indication. Now, if I get someone who's adopted and they're diagnosed with cancer, I'm like, let's just test you because, you know, now you've been affected. We can look. Now, are there opportunities for people to pay out of pocket for genetic testing if they want to know because they're worried about the limitations of their knowledge? Yes. And some of these genetic tests can cost people roughly about $250, $350. And they can do a full gene panel encompassing anywhere between 47 to 91 genes. And these are just specific to hereditary cancer. Remember, we have 21,000, 25,000. So, yeah. Any other questions? Yes, ma'am.
Yes, thank you. Very fascinating. What type of a healthcare system would one need to be in, any one of us perhaps in this room, to be able to give you a call and say, hey, would like to be tested?
So essentially, I receive referrals from any healthcare provider. So I see oncologists that refer their patients, primary care, gynecology. I've actually had a dentist send me a patient where I was before. So really, anybody, if you have a healthcare provider and you are worried about your family history, they can refer. I even see people from the VA.
Thank you, Danielle. I am adopted, so I was going to ask you the question this gentleman asked. So I'll go one step deeper on that track, and I'm about to maybe make a trip this summer to the only surviving aunt that I have who has cancer, and so I'm going to try to trace family history, both biologically and adopted, but obviously biologically is where I'm going with that because she was working at the hospital that I was adopted from, so she would know. So how far do I need to go in order to get, you know, your red flag up as to whether I should need testing or not?
So I always, when I sit with patients, I try to kind of construct a 3 to 4 generation pedigree or family tree. So I'm looking not only at that patient's, you know, lineage, I'm looking at their parents, brothers and sisters, their grandparents, great aunts and uncles, great grandparents, and even first cousins. Again, I tell patients all the time, we can only work with what you know. I mean, there's going to be family history that we're never really going to have a clear understanding. So whatever you can find out, you know, is great. And I'm glad that you were able to track someone. This is a biological family member, correct? Okay. So okay, gotcha. So she would know some of the family history there. No, that's great. And oftentimes most of the family history I get is word of mouth. It's not confirmed medical records. Because again, grandmother died in 1912. Good luck. Yeah. I mean, you know, so it can be very difficult to find that, but I do hear some very interesting family histories. I will say that.
Great
So,
presentation.
thank you.
You answered my question already about the cost of the testing. Does insurance cover that?
Absolutely. Early on, it was a very expensive test. And what's sad about it is early on, it was limited too. We were only looking at a handful of genes. Now for patients who meet testing criteria, I will say this, and I say this with all confidence, I've been doing it long enough, 99% of my patients don't pay anything. It's really covered in its entirety. Some insurances are now kind of bringing it on as a preventative screening, which we all know preventative screenings are 100%, but very rarely. And if I do have a patient that has any out of pocket, it's usually $100 or less. Not much at all. Yes, sir.
A strong message, valuable message.
Thank you.
For prostate genetic testing.
Yes, sir.
Is it a serum test or a biopsy test?
Blood.
Blood. Wonderful.
No, it's not an eyebrow,
Not an eyebrow.
not a prostate biopsy. Yeah.
And the second question, testicular cancer. You did not mention it.
So those are some of the germ cell tumors, and we are looking at them. So there are some specific genes. So usually when I talk to patients, I'm really asking them about all cancers in the family. So, you know, every once in a while I will get, you know, someone with a, you know, testicular cancer, Sertoli-Leydig, which is the type of rare ovarian tumor. And those will prompt me to think maybe about less commonly occurring mutations. But we do comprehensive testing. So that means we're not just limiting patients to necessarily disease specific genes. That means if a woman comes in and says, 7 women in my family had breast cancer, I'm not going to just focus on the breast genes. The reason that is because in doing that, we will miss about 30% of mutations. Yes. Sorry. Oh, sorry.
Hi. Thank you.
Uh-huh.
Could you talk about privacy? I understand I've read a couple of stories about 23andMe being owned by the Chinese, and they are mining that for data and such.
So the clinical laboratories that I use, do have to abide by HIPAA. They do not sell your information to big pharma or anything like that. It's very protected. And as far as hereditary discrimination, individuals are protected by a federal and state law called the GINA Act. It does prevent patients from hereditary discrimination as it relates to their health insurance or their employment. Now, federal employees, active duty military, they're not under the GINA, but there are separate laws that help protect them from that. But hereditary discrimination is not something that we really see, but there are things in place to protect patients from that. Does that answer your question? Okay.
Great presentation. So I grew up in a place there's no healthcare system. So I started healthcare system at age 15. Didn't have any background with my family, but I'm in public health, so prevention is better than cure. What happened to my children, let's say, to start with me, just in case, and what should I do here, just if I'm concerned with my children and not my mom and dad?
Right. So you're saying like if you were to test and come back positive, is
not just thinking ahead, just in case. So I can't go back to my mom and dad because I don't have any history.
Got you.
But
okay.
I don't know the X, which is my genetic background.
Okay.
But in case now it will start with my children and I, in case I do have one, to protect them.
Right. So I guess too, like if you were to be diagnosed with cancer, let's say you develop cancer, we do genetic testing and you're genetically positive, depending on the age of your children would determine when they would need to test. Most of these hereditary cancer syndromes are adult onset. So oftentimes we will not test offspring unless they're 18 years of age or older so that they can consent. However, there are some pediatric syndromes where I have had to test minors because they do require screening at young ages due to that. But I will tell, how old are your children? Just okay. So young. So there's a lot of potential for a lot of advancements in genetics because genetics updates about every 5 to 10 years. But I'll be honest, I think we will see probably sooner rather than later, young women going in for gynecologic exam and we'll be doing, like I said, some form of population-based testing for some of these more common, genetic mutations. So I do see it becoming more of an impact. But I always tell patients, your family history should be updated every visit, at least every year, because family history can change from one day to the next. And I always tell my patients, communicate the family history to your children, encourage them to communicate it to their children because that will matter. Yes, ma'am.
Excellent program.
Thank you.
I feel obligated to let everybody in the room know. I think one question that many of us have is where do we get this done? And you're saying you have to have a referral. Dr. Chris Chance, who is a local chiropractor and whose wife Mary is a member of this club, is associated with a lab here in Gainesville that does do these tests. He gets no part of the fee for doing the tests, but I personally would recommend, as I have done this myself, and fortunately I had no drawbacks in my tests, but that is where you could contact someone if you don't have another physician that could make a referral to have this done.
Thank you.
Danielle, thank you for a wonderful presentation. I think someone used the word fascinating. Just such a relevant and informative, just interesting to all of us. And that can be said about your profession, the specialization of healthcare that you operate in. So thank you for that. This is a wonderful presentation. I enjoy it when we have truly an outsider from Rotary. as a speaker because I like to just kind of introduce Rotary to you. And we have a parting gift for you to kind of remember your talk. Rotary is 1.4 million members globally. Obviously, that's a diverse swath of citizens who are engaged and really care about the world, about their communities, about their global communities. But you know, these are folks that are you know, like I say, truly engaged to make lasting change around the world. And our motto is service above self. And the coin I have for you has that on one side. And on the other side, another kind of distinction about Rotarians that maybe separates us from other philanthropic groups is that we aim to adhere to a certain code of conduct in our interactions with each other, our interactions with friends, business associates. We're guided by something called the 4-way test, and that's on the back. The 4-way test is something we run by everything we think, say, or do. We ask, is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? And will it be beneficial to all concerned? So this is for you, Danielle. Thank you again for your time. That was a wonderful presentation. Okay, and we had some intelligent questions out there too, I thought. So that was great. Wonderful presentation, great meeting. The last 3 digits of the 50-50 drawing for the Rotary Reading Safari are 234. 234. This meeting's adjourned. See you all across the street next week back at the Rotunda building.